Mycetoma is one of the most neglected tropical diseases affecting the poorest of the poor in remote communities. It is reported worldwide yet endemic in many tropical and subtropical regions in what is known as the Mycetoma belt, and Sudan seems to have the highest endemicity. The disease commonly affects young adults, mostly males aged between 15 and 30 years of age in developing countries. People of low socioeconomic status and manual workers such as farmers, laborers, and herdsmen are the worst affected. Mycetoma is commonly seen in communities with poor hygiene and environmental conditions, where the population live in close proximity to animals. It is believed that the traumatic inoculation of the causative microorganism via thorn pricks and minor injuries is an important route of mycetoma infection. This is supported by the fact that mycetoma is seen more frequently in the feet of patients with low socioeconomic backgrounds, with poor hygiene, and in villages with animal enclosures made of thorny trees. The majority of patients present late with advanced disease and serious complications, and the cause is multifactorial. The painless nature of the disease, patients' low health education levels, and low socioeconomic status are very important factors. Furthermore, the late presentation is due to the scarcity of health services in distant, isolated endemic areas. Hence why the patients tend to travel from their remote localities to central specialized centers for diagnosis and treatment. This causes a very high financial burden on the patient and the patient's families, and most importantly, a delay in treatment initiation. The disabling nature of the disease hinders access to healthcare service for the majority of the patients. The late presentations often necessitate amputation or destructive surgical excisions, resulting in massive disability and deformities. Usual mycetoma patients need prolonged periods of management involving diagnosis, treatment, both medical and surgical, and regular follow-up. Treatments may last at least 1 year for the minor lesions to resolve and several years for large lesions. Even after full recovery, patients need to be followed up closely for evidence of reoccurrence, which is not uncommon. As it stands, there is no point of care diagnostic test for mycetoma, and thus patients need to travel to specialized centers to establish the diagnosis and treatment. The available therapies have proven ineffective and expensive, with a range of side effects and a high reoccurrence rate, particularly for EU mycetoma. Its cure rate is low, about 28%, and the patient's follow-up dropout is high, about 54%. Patients require long-term follow-up to monitor recovery and recurrence. The rate of amputation in mycetoma is high, and it ranges anywhere from 10 to 30%. The thing is, amputation in developing countries is a social stigma. It has various financial and psychological impacts on patients, their families, and their communities. It is a crucial cause of poverty and economic loss in endemic areas. Students tend to drop out of education, workers and farmers lose their jobs, and for the women, in these communities, amputations forces them to put an end to their social lives. This makes it difficult for them to marry and raise families, and in many cases, led them to divorces. Many of the amputees start to move around, begging just to earn a living. Some of the amputees use poorly designed, local, primitive material, self-made prostheses. These prostheses are heavy, difficult to use, aesthetically non-pleasing, and not socially acceptable. With this background, and as part of the holistic patients management, the Mycetoma Research Center, in collaboration with the Ministry of Health, Sennar State, and the Zaki Fund, had launched a national campaign to provide free artificial limbs prosthesis for mycetoma amputees in endemic villages in Sudan. A mobile artificial limbs prosthesis workshop equipped with an expert technicians team, equipment for prosthesis manufacturing, physiotherapy, and raw materials was moved to the Mycetoma Satellite Center at Wadonsa village, eastern Sennar locality in Sudan, one of the high mycetoma endemic villages. To say the least, the team was well received at the village by the amputees, villagers, and local authorities. They spent about 3 weeks in the village and managed to provide prostheses for 160 amputees and some even had bilateral prostheses. In addition to this, they had also provided training in physiotherapy for the amputees. The prostheses had had huge impacts on the lives of the amputee and their families. Some students resumed their education, while others continued on with their normal daily lives. The campaign had alleviated the financial burden on the amputee and their family, as most of them could not afford the prosthesis cost, travel, and accommodation at the big cities where the prosthesis production centers are. To find out more about mycetoma and how you can help, visit www.mycetoma.edu.sd.